I thought that I would perhaps talk a little bit about clinical education, seeing the theme this year is the science of caring and the challenges that we are currently facing. So I work in an urgent treatment center, which also has a surgical side to it, where we do minor operations. But the urgent treatment center side is where we see on the day cases with people with injuries and illnesses. So they just present without any booked appointments. That's what urgent care is. They recently changed the wording. So our presentation is going to contain the background of these centers, the limitations, national and local limitations. We're going to look at a plan to educate people in the department, our objectives, short, medium and long-term plans, the resources that we need, the strategies to deal with challenging students, and how we're going to monitor outcomes. So to get started, urgent treatment centers in this country, they were called minor injuries units, they were called minor injury, minor illness, they were called walk-in centers. It's only recently that the government decided to change the terminology and call them urgent treatment centers or urgent care centers, depending on the service that they are able to provide. So up to now, the places were opened in the year 2000, but up to now, there still remains a lack of clarity as to what constitutes a minor injury or minor illness, the roles that the nurses or the paramedics or the GPs are expected to perform compared to their other usual jobs, the consultation times, because in GP surgeries, the consultation time will vary between 10 and 15 minutes. In our centers, we don't have any time restriction per se, or the training that is required from our nurses and our paramedics. The GPs, it's quite simple. They have to be a general practitioner. Nonetheless, we've seen an increase in the numbers of patients that are presenting. Between the year 2000 2019, we've seen an increase of 3 million people to 9 million people, and those numbers are escalating. It's been worse post-COVID because now there are restrictions in the way that people can make GP appointments. So where people can't get seen by their GP, they end up coming to an urgent care center because they can just walk in whenever they want. So what that has meant is that there's more accessibility for our patients, and these centers are successfully being used by the GPs, the nurses, the paramedics, and the patients that are using them. And we do try to provide the best and high quality of care. However, the challenges in these centers, because of the speed with which the government decided that they wanted the centers to be open, which was 6 months, it meant that there was never any clarity, any guidance as to if we're seeing a minor illness, we mean just a sore throat, or if we're saying we want a nurse practitioner, we mean a nurse that has been trained in this and that. There was never any clarity in terms of that. So we get paramedics who've had a bit of experience, we've got nurses who come from an emergency department background, orthopedic wards and those kind of settings, but there's no standardization as to what education is actually needed for practitioners who are going to be working in these kind of centers. And as such, because they then come to these new environments, they don't know what to expect either. So we end up losing a lot of nurses and paramedics because they're not coping with the demand of these urgent treatment centers. On a daily basis, we can on average see about 200 patients, and that's among about 5 to 6 nurse and paramedic practitioners and 1 GP. In our local urgent treatment center, the challenges as national is retaining staff, it's recruiting staff. So although we've recruited them, they don't last very long. And it's also the training needs. There's a lot we say to them during the interviews, but when it actually comes to working, we don't we don't offer what we had said we're going to offer during the interview. So on their exit interviews, we try to encourage people to sit and chat as to why they're leaving. So some of the feedback that we've been giving, practitioners have said that they've been overwhelmed. The job is more than what they are able to offer as an autonomous practitioner. They felt out of depth. They felt that they haven't been supported, and they felt that they haven't had enough training to actually perform the role. As such, we've had to then come up with ways that we can try and support. So currently we've got a new model of care where we were trying to reduce the staff turnover. We're trying to reduce the shortages in staffing levels and the skill mix. So we're using the feedback that we got given during the exit interviews to actually try and improve our staffing issues. There are always going to be company-related problems like sick leave and salaries, management support. That's different. We're just talking about the clinical aspect of things. There are the Royal College of Nursing and the Royal College of Paramedics is now also acknowledging those differences where there is no standardization as to what is needed for a person to call themselves an advanced nurse practitioners. So there is work going on nationally where they are trying to standardize, where they are saying, for instance, they want the nurse practitioners and the paramedic practitioners to have a master's degree in nursing or advanced practice for them to work in these kind of centers. But what we're actually doing now is trying to develop our own practitioners while trying to look at what is being done nationally. So we're trying to do this because we're trying to increase our standards of care. We're trying to make sure we're safe with the patients that we see. We're trying to make sure we're providing holistic patient care. We're trying to make sure our patients are satisfied, we're accountable, we are transparent where we've gone wrong, we're learning from the complaints and mistakes that patients have given us, but we're developing a workforce that's going to be able to manage whatever comes through the door. For our clinicians, we've got this vision and plan because we're trying to make sure our practitioners are autonomous, they are confident, they feel supported, they are not wanting to leave because they feel there's no support, they are safe in what they are doing. But we're trying to also make sure whatever training program that we're giving them, we're working with the local universities to make sure that those courses are accredited. We're not only looking at the new staff, we're also looking at current staff as well. People as old as me who's been here for so many years, I mustn't get left behind as well just because I've got the experience. I need to make sure that I'm up to date with what I'm doing as well, evidence-based practice, but we're developing so that we go from our junior staff to senior members of staff who can then take charge when there is a need. But as I said, nationally, the Royal College of Paramedics and nurses, they're also looking at how we can standardize the role. So we're making sure, or we're trying to make sure we're conforming practitioner, which is clinical practice, which is education, which is leadership, management, and research. So the way we're trying to do that in our department is then by making sure that we screen our practitioners when they start. We're trying to get some baseline as to where they're coming from, what they already know, what they do not know, how we can help them to settle in the role. So we're identifying those individual needs, but we're also trying to identify the team needs as well. Is there anything in particular that the team wants to learn about? So taking those into consideration, we're then trying to educate accordingly. So we're trying to have one-on-ones, so that person who wants to learn, for instance, how to use a slit lamp or how to examine an ear, you work individually with them. whereas you might get a group of paramedic practitioners who haven't been involved in, for instance, cervical smears. They don't know how to use the speculums, so you might do a group session on the use of a speculum. So that's how we're going about doing the training. We're looking at short term. So short term is working with the individual. So they've started today. So within 3 months, this is where you want them to be. And from there, this is where you want them to be between 3 and 6 months, or medium goals. And that doesn't only include the individual practitioner, but the group practitioners as well. We're working with the local universities, we're working with consultants in the surgical center part of things. So we've got orthopedic consultants, for instance, we've got ophthalmologists who are specializing in specific things that we could take and use in our department, because we see anything and everything in our department. So those patients who are coming in with red, painful eyes, what can we learn from our specialist ophthalmologists? Is there anything that they can come and train us? But we're making use of the universities as well. Visiting lecturers come and teach us about examination of a throat, for instance, examination of an abdomen. How do we go about doing that? So individual and group sessions. I've already covered that. So we're not only looking at that, so you're not only trying to teach, but you're also trying to get some feedback from your practitioners as well. Is there anything that they want to feedback? Is there anything that they know that they can bring into the department that you can share with the team? We wanting to do clinical supervision so they don't feel left out. You spend some time with them, say for instance, after they are 6 months, especially the new ones, 6 months end of probation, you sit down with them. Where were they when they started? Where are they now? We're doing annual appraisal. So from those, again, you are using your baseline. This is where we were when you started. This is where we are now. How do we help you to progress? We're using reflective practice. So anything that a practitioner has seen, would like them to reflect on that, would like them to feed back to the rest of us, because although perhaps some of our practitioners are not saying anything, they might be in the same boat as well. So if someone can share practice, it's helping all of us to learn. But we're not only looking at our own practitioners, we get students as well. We've got GP learners, we've got student nurses, we've got student paramedics, we've got student optometrists, we get all sorts of students in our center. So we're trying to support those as well to get the best possible learning that they can get from this surgical center, which has only about 200 employees, both clinical and non-clinical. So we're small, but we are trying to play our part in making sure that we are using evidence-based practice. We're keeping up with what's happening in more teaching hospitals in bigger organizations and things like that. We're trying to make sure that our practitioners, they've got their portfolios, so that even if they were to leave our establishment, they can take their portfolio with them, which will help them wherever they go to. Or if you send them on an academic course because they are ready to develop, they can use their portfolio of evidence as well to show what they've been doing, where they were, where they are at that particular point in time. For us to be able to continue with our learning and development program, we need to make sure that we've got the support of our higher managers, so the hospital director, the head of nursing, our clinical governance managers, everyone. We want to know that they are engaged. We want to know that they are supporting us. We want to know that they're actually going to give us the time to deliver these programs. Otherwise, there's no point. It's not going to work if that's not happening. But we also want to put policies, or trying to put policies in place, and SOPs as well, how we're actually going to be doing this, when are we going to be doing it, how we're going to do it, and we're learning from those as well by doing audits. So where were we when we got started? Where are we right now? Where do we improve? What needs improving? What needs tweaking from the program? Which is why we then encourage our new starters, we encourage our new students, we encourage everyone. Please give some feedback as to how you felt on your first day, for instance, or the training that we sent you to. Give us some feedback so we know how to do things better in future. We're working with other groups as well. As I said, we're working with the local universities, we're working with consultants in the surgical part of things. We're looking at working with reps as well, so that they can come and offer us whatever they've got that might be new, that you might not know about, because obviously we are in our own environment as isolated here, so we're trying not to be isolated. There are also other multidisciplinary teams like the inspection regulation bodies, the integrated commissioning group, safeguarding networks, district nurses, outside GPs. There are a lot of people that we're working with. We're working with the local hospitals as well, but we're trying to make sure we're not being left behind. We are doing and trying to conform to current practices that other people are practicing, while learning as well, because obviously we are adult learners now. We need, as an educator, we need to make sure we understand the learning styles of our adult learners, so we need to take those into consideration. Sometimes you think that you've got a challenging student who's a bit stubborn, or they don't want to listen, or they don't want to learn. It might actually not be the case. It might just be you're using a different approach, you're using an approach that they're not familiar with. So you need, as an educator, you need to know the learning styles of each of your practitioners, so that you are able to support them, you are able to guide them, to give them the best possible way to help with the learning. The way we are monitoring these outcomes, as I said, we are doing audits, we are looking at their reflective journals if they are willing to share. We are getting feedback from clinical supervision. We're looking at our time frames, the time frame that we gave, have we been able to deliver within that time frame? We're looking at record keeping, we compare notes, we sit there, the managers meeting, so you're sitting with your GP lead, you're sitting with the leads of the department, you're sitting with your clinical governance to share practice and give feedback and get feedback as well from what they are doing, what they've had, and how this impacts on patient satisfaction and patient care delivery. And in conclusion, there are still a lot of challenges. It's okay putting a plan in place, having all these beautiful and wonderful ideas, but actually delivering the program, that's another challenge. And making sure we are retaining staff, that's another challenge as well. As I said, it doesn't only include us and our transparent educational program, but there are other factors that people might be looking at as well. For instance, if you're being offered better salary somewhere else, you would leave. You wouldn't want to stay where there's less of a salary. So it's not just looking at the educational part of it, but it's looking at all of those parts. Those that are wanting to leave is trying to see if there's anything that we could improve on that might perhaps help them to stay and not leave. I think that's all from me. I've said a lot in a very short period of time. There is a lot more that I could say, but that's the gist of it. We're looking at an innovative and transparent internal educational program for our paramedic practitioners, our paramedic nurses, our GPs who are coming from different settings, but also our future leaders as our student nurses, student paramedics who are here for perhaps 7 to 8 weeks. We're trying to make sure we're including everyone in our educational development. Right here, that's all from me. I've got the references there. Thank you for listening, and I will take any questions if you've got any.